everybody. If you're here, I'm happy to see you. Come on camera if you can. There we go. We are officially streaming. Okay, good. Hey, Lori. Hey, Rhonda. It's good to see you. Who else is here? Laura, Ronnie. Beautiful. I'm so glad you guys are here. Come on camera if you can. Stay off if you can't. Join in to whatever level appeals to you. If I've not met you before, I'm Gina Schatz. I'm your host. If I have met you before, I'm still Gina Schatz and your host. And I'm the developer of the Schatz method, here to talk to you guys about functional anatomy, Training Tuesday for practitioners. Whoop, whoop. It's one of my favorite times of the week because it's kind of casual. It's also a little stressful sometimes. I'm going to be honest with you guys because, you know, it's like moving conversations, and I still love to answer your questions. So if you have any questions for me as we're moving through today, please do let me know. I'm happy to support in that way. Think about it like, instead of being too nervous to ask a question, think about it like I'm on the hot seat. So I'm the one that's nervous. I'm not nervous though. Nobody gets to be nervous. We just gotta get to play. So hi, welcome. I'm glad you guys are here. Lori, I liked your background. You changed it.
I'll put it back. It always cuts, you know, it always cuts off weird. It's a silly thing. I'll put it back.
Yeah, but I do love that did you make it for everybody on the team? You did? So exciting. Lori's one of our anatomy advocates. She's a graduate of the mastery program, and she knows all the training and all the deals, and she's on a team of amazing practitioners. And not only are they amazing individually and super freaking talented as practitioners in their own right, but collectively they're volunteering to support other practitioners in the community. I mean, it just doesn't get better than that, right? So Lori's one of our anatomy advocates. Thank you for being here. Love you for a million reasons. And we got somebody new coming in. Beautiful. I'm glad you guys are here. I'm glad everybody's here. I hope it's sunny where you are. Where I live, it's not always sunny, and we've had like a kiss of perfection in the last few days. So my energy is high and my soul feels nourished from the sun. There's nothing like a little bit of good vitamin D. So welcome. Last week we talked about mobility and the differences between mobility and flexibility and range of motion. I'm not going to give you guys a pop quiz, but I kind of want to on what the differences are between the three, because they're not the same. They're not the same. And there it is. Anatomy advocacy. Oh yeah, you're right. I do like it. I do like it better when you move and I can, yeah. I wonder if that's, well, if it was, I was going to say, I wonder if it was because of the color, but if it was a darker color, it would blend in with what you're wearing and then you'd be a bobblehead. So it's all good. I like it. Use it if you want to, Lori. There's absolutely no, no commitment for you to put that on at any time. So thank you. Whatever works for you works for me. Okay, guys, practitioner speak. Here we go. There's a difference between mobility, range of motion, and flexibility. For those of you who were here last week, I know you know it. There will not be a pop quiz, even though I want to. For those of you who did not yet see that training from last week, I highly recommend it. Highly recommend it. This is a game changer when it comes to putting together effective treatment plans, for sure. And resolving problems, which sometimes can be a mobility problem, right? It might not even be soft tissue that you need to dig your elbows in, dig your thumbs in, or stretch. In fact, most of the time it's not. And I've said that forever. Most of the time we do not need to stretch someone or massage them deeper. That's not the solution that they really need. So I have a question for you guys who are here. Those of you who are here on camera, awesome. Those of you who are not here on camera listening in, please feel free to use the chat, or you can also speak if you aren't able to come on camera. Welcome, Drew. I saw that you came in too. I'm glad you're here. So question for you guys, how has mobility shown up with the work that you do with clients? How has mobility shown up with the work that you do? And where did it become sticky for you? So where did mobility show up for you in the work that you do with clients, and where did it become a sticky point? Meaning it was in the way of something that you were trying to accomplish with a client, or you think that it is, after listening to last week's training, that it actually was the culprit for why you didn't get results, or you don't really have a full yet handle on mobility. So you know that something's up, but you can't quite pinpoint it. So it's any one of those types of sticky points or any other type of sticky point. So what do you think mobility has done for you in your treatment plans? And what was the sticky part? How has it shown up for you, and what's been tricky about navigating it? Sort of the basis for what we're going to talk about today. So I'd love to hear from each of you. How has mobility shown up? And if mobility hasn't shown up because you don't know mobility, just tell me that. Just be like, I don't know. It might be showing up, but I'm missing it. That also lays a foundation for what we're going to talk about today. So how has mobility shown up for you, and where has it been a sticky spot? If you guys are typing, I'll give you a minute. Sometimes quicker to just come off mute and tell me how has mobility shown up, and how has it been a sticky spot? In what ways has mobility interfered with something you were going to do with a client? Okay, Laura, what's up?
So where it showed, I was thinking in the past where it showed up is when, especially in yoga, because we want to lengthen everything until now, which we don't. I feel like I'm a floating head. I know
it gave you a haircut.
It's really weird. It was in the past. I think I always, and this is many, many years ago, but I always thought that everything needed to be lengthened. Muscles needed to be lengthened or stretched. Mm-hmm. And when folks, when I would put them into a pose, they would say, oh, I'm not feeling that. And I'm like, oh, well, then you need this. Again, this is way in the past, but you need to go deeper. You need to go further, all of that kind of language around it. Mm-hmm. And it never occurred to me until it occurred to me that it was like, you could go as far as you want, but if you're hypermobile, you're not going to feel anything. Mm-hmm. So that was where, looking back, that I was like, Mm-hmm. So I would encourage them, just go further, just, that whole language. And that's where it would be sticky. Now, certainly I know differently. Yeah. But, so I don't know if there's yoga teachers in the room and if we're challenged by that. Yeah.
Good to hear from a former, yoga stretcher.
Yeah, right.
Yeah, we've all been there. I've learned along the way as well. Mm-hmm. And I love your answer because, well, a couple things, and I'll come back to it, but the need for stretching, whether we do need to stretch and whether we're supposed to feel a stretch, these are sometimes confusing. And that is even separate from the conversation around mobility. But it definitely changes when we start bringing in the conversation of mobility. So thank you for bringing those up. I'll come back and touch on those. Thank you for starting and going first. Who else here would like to share, please do, how mobility has shown up for you in the work that you do with clients? Laura, your backgrounds are cracking me up. And where did it become a sticky point for you? If it's not been a sticky point, then I'm going to change the topic for today because I don't want to talk to you guys about something that's not going to be of value to you. But I really think this is a valuable conversation. So I'd love to hear from you. How did it show up for you? Rhonda, how has mobility shown up for you? Now, we've been chatting together for a few weeks now, and you've joined in on a conversation on mobility. What's come up for you around that with your clients?
Well, I've just been noticing areas of hypomobility in my clients and trying to work in those areas.
Okay, awesome. And so how are you knowing that it's hypomobility, and what are you trying to do for them?
So I check range of motion, and if they don't have any, I start working in that area on the shortened side of the joint.
Awesome. And when you start working on the shortened side, what work are you doing? Not everybody knows what you do. I know what you do, but not everybody here knows what you do. So what work are you doing on the shortened side?
Well, so I'm a body worker, and so I'm applying pressure and gently moving the joint for it to understand it has more range.
Mm-hmm. Awesome.
More mobility.
Yeah, beautiful. Okay, and has that rendered the results that you wanted up until now?
Yes and no. I mean, it gives the client temporary relief, but if they don't take what I suggest to them out into the world, they come back with the same thing a week or a month later.
And so if they're, and we're talking about hypomobile clients, hypomobile constitutions.
Yeah.
And what are you suggesting for them? What do you think that that constitution of mobility needs?
Well, I suggest that they move differently, adding different directions of movement to what they do. Offering different activities for them to try, or to move their desk or their mouse or their phone, or, you know, different lifestyle changes to
So
take with them.
Posture changes or movement functional changes? Or
both?
Both. Okay, cool. Hey, Joan, glad you're here. Okay, awesome. So based on what we talked about, go ahead, Rhonda.
So for example, one particular client constantly has their right leg rotated out. So the foot is turned out, the knee is turned out, the hip is turned out. And I think I've been seeing this client for 30 years, and I talk to them each week about having their toes and their knee point in the direction that they're going. They never do it. I don't know, you know, I can't force them, I can't follow them. And so they come every week. And they see many practitioners, not just me, because they have a lot of pain. But I can't change who they are or what they do when they're not with me.
So what do you think is causing their choice in body pattern in that way?
They don't want to be bothered.
It doesn't sound like that to me. If they're seeing a whole gaggle of practitioners, they're very bothered, and they're proactive.
Well, they're bothered because they're in pain, but they can't be bothered to change their life patterns.
So if we took the character and the person out of it, what do you think the function would be? What functionally is happening that is making that the resting position for that body?
Tight hip rotators, particularly glutes and piriformis.
Okay, glute, which glute?
Well, actually rotators, yes, posterior hip rotators. Glutes don't do rotation.
Right. Although glute med does a bit of medial rotation. So if you're, that's why I asked, were you talking about the figure system, or were you just, you know, misspeaking and bringing in glute max? So I love it, Rhonda, right? Because what I heard you say was that what you're doing for your hypomobile clients, maybe this one in particular, and maybe several of them, is that you were offering moving the joint. Amazing. Body's designed to move. We all get to move. And we get to know what joint action we're creating. So what movement is happening or not happening based on the muscles that do that movement. So one thought that comes to mind as you're talking about, well, I have a couple of thoughts that came to mind, actually. Are you okay with this kind of feedback? Yeah, great, because I love it. I love serving in this way. And it's just good for all of us to think this way, right? And what we're talking about here is just straight up anatomy. It's not about whether we're smart enough as a practitioner, whether our clients want to be bothered. It's not about any of that. It's not about character, personality. It's not about that. What we're talking about here is straight up anatomy knowledge, straight up anatomy and functional anatomy. Also not meant to point fingers at anybody. Sometimes we get to have a refresher or just look at it differently. So one of the things that I really appreciated for my own work is I got to be really clear on the joint action, which I'm hearing you are, great, which is awesome, Rhonda. But we all get to be super freaking clear on joint action. And then the very next thing is to get clear on the muscles that do that joint action. Sometimes we get to brush up on it. There are 600 muscles. It's not a dig on anybody, but we get to just keep being really refreshed. Just like what just happened here, right? You can like mistakenly go, oh, glute, and then start working on glute max and be like, what am I doing? It's not glute max, like, right? And so we want to just be like, super efficient is what we're talking about, like good results with clients. So what's the joint what's the joint action? What's the joint that's problematic? What's the action that it can't do? And what muscles do that job? Meaning what muscles contract to do that job. And then the other part that I was wondering if you were asking, which is when I asked for clarity, Rhonda, is what's the muscle that allows that movement to happen? Right? And that's straight up lever system. We've talked about this a few times, always bears repeating. It's like a good place to go. Like, oh yeah, like go back to the basics and it's easier for me. I don't have to make it so complicated, practitioner says to themselves. So it's the muscle that's doing the action is the muscle that's contracting. And then there's a group of muscles that allows that muscle to contract, right? In order for the elbow to bend, the bicep contracts, the tricep allows it, and vice versa. Super easy to think about in a lever system, a little more dicey when we start talking about a 360 ball and socket joint, like the hip, totally fine. So, and these are like principles of anatomy. If this is like, wow, I should know this, awesome. I have free resources on my website. Please grab them. Joint action matters. What muscles do the joint action? The lever system matters. Please know that. And Rhonda, what I'm loving about your share is that sometimes this conversation doesn't land with practitioners that do manual work, but it's absolutely the same, whether we do manual work or movement work. It's the same because the movement is what's causing the pain, or the inability to do the movement is what's causing the pain. So all of us, movement and manual practitioners, we all get to know the same stuff. It's not like specific to just yogis or just massage therapists. We all get to know the same stuff. So back to your specific client, Rhonda, a question that I had for you was, beyond it being, and by the way, amazing recognizing that the pattern was asymmetrical. That's never okay, especially when it's close to the sacrum. Whole ball of wax of pain. No wonder this person's not getting the results that they're looking for because the problem is so central to their structure, for sure. And awesome that you pointed it out, noticed it, and then pointed it out, and even invited them into some changes. The reason why they're not willing yet to do what you're asking is because there's something that still gets to be uncovered in why that feels like a resting position for them. Because we know it's not neutral for the joint. How do we know it's not neutral for the joint? Because we know joint action. So we go back to the beginning. We know what joint action is. If there's action in a joint, it should be moving. If the body is in a pattern of posture, there's no movement. You're either holding a position or there should be neutrality in the joints. It's one or the other. Like, so for those of you who do, hatha yoga and things like that, or even right now as we're all sitting here in a learning environment, we're either holding our posture in optimal alignment of the joints, or we're holding our posture and position to change something. And if one of those two things isn't happening, our pattern is not okay. Otherwise, we should be moving if the joints are moving. If there's joint action, there should be movement. What is that, Lori? Oh, that's amazing. Thank you for sharing that with everybody. See, advocacy team is like on it. Okay, so awesome for you, Rhonda, that you noticed that in this client, one joint acts like it's going somewhere. It's not, because the person's just sitting. What the heck is that? Or even just standing. And so you recognize that it was lateral rotation. So again, we get to know joint action. And my question for you is, A, when we recognize the joint action that's happening, did you check the other side of the lever? And it's a rhetorical question. You don't have to necessarily say yes or no. I'm not putting you on the spot. But always when we know that a muscle's doing a joint action that we don't want it to be doing, there's the other side of the lever. And this is when the lever system goes awry. Either the muscle that's supposed to be doing the job isn't doing the job, or the other guys on the other side aren't allowing it, or the other guys on the other side aren't also holding their own and doing their job. So if you think about, like, both sides have to have equal length and equal strength, equal length and equal strength. If there's an adequate amount of strength on one side of the lever will go that way. if the other side doesn't have adequate strength to hold it central. So if this side of the lever system has adequate strength, not even too much, but adequate strength, not even tight, just adequate strength, and this side does not, it's going to move because there's more tone here, right? And the same is true in tension, of course. If there's more tension here and not enough length to balance that out, or not enough strength to balance it back out, it goes both ways. So I feel like I got a little bit tongue-tied there for a second. I want to make sure I land this really clearly for those of you. I don't know, I felt like somebody who's here that's not on camera was like, what? So let me just go over it one more time. And if it was you, please put it in the chat so I know who I'm talking to and where the question of clarity came from. Okay, in order for me to hold a joint in neutral, there's got to be equal amount of strength, contractibility, contractility, and engagement on muscles that do the prime action on both sides of that joint. Has to be. Otherwise, the side that's strong takes the joint, even if it's not too strong, if it's got its adequate amount of strength. The same thing goes for the lengthening side of the lever system. If this side has adequate strength, but this side doesn't allow it to go, it'll look like this side doesn't have any strength, but really what's happening is this side's not allowing it to go. So both sides of that equation both sides of the lever system get to be looked at. Are both sides contracting? Are they contracting at their same amount of power? And are both sides allowing, meaning they lengthen and they have elasticity? And so always look for that. Always look for both sides. Otherwise, this will feel like neutral. Like that's where your client's leg is run up, just a little askew, right? That feels neutral because this is the resting place potentially for the amount of strength that's available here and the absence of strength that's available here. Potentially, just an option, right? The other thought that I had, I'm glad you're nodding that that's landing, so cool. The other thought that I had when you were talking about the hip joint specifically, and I would use the same for ball and socket at the glenohumeral joint, is it only lateral rotation that's happening, or is it also abduction that's happening? Because especially if we're seated, it would be difficult to have lateral in a seated position with hip flexion act. So let's just look at all the joint action. If you're seated, there's also hip flexion happening. Mm-hmm. And so what muscles do that, and do they play well with the others? Because lever systems all work together in concert in a ball and socket joint. And so are all the joint actions that are happening equally balanced on all sides of the lever? And when we're in hip flexion, it's difficult, I think, to only have lateral rotation of the hip without also having abduction, which brings in a whole other lever and a whole other set of muscles.
Okay.
So
they did have uneven length of legs. Mm-hmm. So there certainly was torso twists, sacral twist, pelvic twist. They had hip surgery, hip replacement surgery. They've also had back surgery. And most of the time, pretty much any time I see them, their leg is rotated out, whether they're sitting, standing, lying, supine, doesn't matter.
And this was the side that they had the hip replacement on?
Actually, they've now had both hips replaced.
Mm-hmm. So was this the first one or the second one?
Second one.
Okay, so this one was compensating a lot for the first one being problematic first.
Yeah, the first one was the longer leg. So the hip was hiked high.
Before the surgery or now?
Before the surgery. He will not give me the surgical notes, so I do not know if the doctor did anything to even out the leg length.
So who told you that there was a leg length discrepancy?
Well, I could see it And he certainly told me.
Okay, so interesting, Rhonda, when you said the hip is hiked. 99% of the time, when there's a leg length discrepancy, it is from the hip hiker muscle. It's not from actual bone changes, like bones are longer on one side than the other. Pre-surgery.
Well, QL is always short.
So if QL is short, it's hiking up the innominate, which is making the leg look shorter.
Mm-hmm.
Yeah. So that would be QL issue. It has not. It's not about the hip. It's QL.
Yeah.
Okay.
Well, but that's the left side, and we're talking about the right.
Sure, but if the left side's hyped, the right side's got to balance it out because
Yes.
the body works on diagonals. So
Yes.
rather than just continuing to tell one side of the body to do something different, if the body says no, we get to look at what's the reason.
Okay.
Yeah. So, and I just want to emphasize here that once there's, depending on the surgery and where the surgery is and how much of the hip was replaced or knees, or if there's ankle pins or things like that, mostly with knee replacements more than hip replacements, have I seen an actual leg length discrepancy. But again, 99% of the time, not surgically related, it's QL. Just trust me on that, go for it. And then it's, why is the QL acting like that? Because that gets to be addressed. Why did the QL act like that? And it gets to be addressed. Now, once there's surgery involved, you probably, and you're noticing leg length discrepancies. I've never seen, well, one time I did, where a surgery was, I would use the word botched in a way where it left the client like literally imbalanced because they used hardware that wasn't the right size for someone's hip, which made the femur appear longer. And that was a whole issue, and it got replaced, right? Like, you can't live like that. And that's a sizing issue. That's the sizing issue of the hardware that they use for the replacement. So I'm not saying never, but I'm saying most of the time, clients are not left with one leg longer than the other because they had a hip replacement. Those two are not one equals the other all the time. It's not like that. But the soft tissue prior to the surgery still has patterns of whatever compensatory work it was doing because the person couldn't walk. I mean, by the time, think about it from the body's perspective. By the time someone needs a hip replacement or knee replacement or back surgery, by the time they actually go under the knife, it has been a long time of trying to avoid that. Mm-hmm. And that long time means new patterns in the brain, new neurologic synapses that are telling the body to move in a way to try to pull away from the pain. The body's never going to go into pain and just hang out there. I mean, think about it, right? Like, we all pull our hand off of a hot stove. Different neurology, but same concept, right? So by the time that your client had his first hip replacement, there was already compensatory patterns that don't get erased after surgery or in surgery. That's mm-hmm. not what surgery does, right? So we still have those compensatory patterns. And now I'm hearing you say his other hip was replaced, which means there's another layer of compensatory patterns stack. We're actually going to talk about that in our masterclass in June. Compensatory patterns stack. And as practitioners, we can really spin around for a long time and get frustrated or lose our confidence or start pointing our finger at, our client's laziness, when really what we're just missing is the layers of the compensatory patterns. It's really worthwhile to look through them, So we know this for this chap. We know that he has 2 hip replacements. Okay, cool.
And lumbar spine.
Yeah. And what happened there in his lumbar spine? What was
I think that was the beginning of the back pain surgeries.
What did he have in his lumbar spine? Did he have a bulging disc, or did he have a fusion, or did he have pins or rods, or what was the surgery?
Bulging discs.
More than one?
Well, there's some in his neck and there's some in his lumbar.
How many?
But we're not talking neck.
Yeah, no, they're connected, right? Like the whole body.
Oh, yeah.
About last week. The lumbar curve and the cervical curve balance each other. So one has to be, so then it's like, oh my God, well, what happened first? So let's just for our moment of conversation here.
So you're saying what happened first? I think it was sprained ankles, but I'm not sure. There's also some, I'd have to look at the record. There's some abnormality of his sacrum, I believe. There's like a part missing.
What part?
I'd have to go back to his record and look. I don't recall, but there's like a piece of the bone that never grew together.
Okay, so you do have the record.
Not in front of me. This is just remembering.
I heard you say he wouldn't give you his records, but you do have some.
No, so he wouldn't give me the records of his hip surgeries, like the blow-by-blow report that the surgeon does when they do a surgery. He wouldn't let me read that, but he has given me case history.
Okay, cool. So, and so we don't know what part of the sacrum is missing. Sometimes it's just the bottom isn't fused. I think
it's somewhere in kind of the lower side, but not the very bottom.
Yeah. And do you know what side it is, right or left?
I'd have to look. I don't remember.
Yeah, because that's also where the deep rotators attach.
Right. So I think it's the left, but I'm not positive.
Yeah, so I would look there too, right? Like if there's we talked about range of motion being bones last week, right? So if the bones are different, the way the muscles attach them is affected. Doesn't mean it has to be permanent because muscles move bone and muscles are changeable. But if we know that there's a bone that needs more support, we use the muscles to create that. We talked about that last week in our mobility conversation. You can't change ligaments and you can't change bones, but you can change muscles. So we need to know what's happening in the ligaments, what their constitution is. And if you do know of a bone abnormality, then you absolutely get to dive into the muscles that support that bone. And by the way, unless it's actually at the joint where there's movement, a bone abnormality doesn't really matter. It can change attachment points, which then can affect the muscle's action, but the action and the movement, not the action, the movement happens at a joint where two bones meet. So if it's not in the joint, like the SI joint, even less of a problem. We just need to make sure those muscles are doing their job and targeting them. And if you're not a movement person and you're a manual person, pair up with his movement person, Rhonda, and make sure that you guys are both working together. You get those tissues ready and aligned, and that practitioner aligns him in movement, and he's okay. There's no issue then, right? And then, you know, he's kind of a deep case, right? Like if it started with ankles, was it ankles and sacrum? And then did the ankles lead to the back and then the back led to the hips, or like what order was that all in? But compensatory patterns stack. I'm just going to keep repeating it because we are going to dive into that in June. What I heard you say though is at the start was that what you were focused on was the difference in his knee and foot and hip.
Yes.
Yeah. So the question comes back to, is that happening? Because there's just an imbalance in the lever system. It's the easiest, quickest place to go. We always start there. Is this just deep six are contracted and adductors are not, or psoas isn't, psoas is, psoas has its own problem? Like, what is the lever system there? And again, it's never one muscle contracts, one muscle lengthens, but we start. But if you're just learning lever system, I really encourage that you do that. What's the main guy that does this joint action after you've identified the joint action? The main guy. And is he doing the job? Because if he's doing the job, then chances are it's the other side of the lever system. It's rare that it's synergists that don't do the job. Unless, there's always an exception, there's a ton of compensatory stacking, which of course in this guy's case there is. So the first place you go is just balance the lever system. Is it working? Identify what the joint action actually is. And like we said, maybe there's abduction going on here in this person and not only lateral rotation. So make sure you check them both. And then you want to look at their alignment. And I heard you say that he has a torqued pelvis and a torqued sacrum. How do you know that, Rhonda? Was that something you measured? Was it something the doctor measured?
When evaluating him, I don't measure using numbers, but I measure with looking at where points line up, where they fall. So where the ASIS and PSIS, how they line up. Are they level? Are they equal? Things like that.
Okay, and you're noticing a discrepancy between the right and the left?
Yes.
Yeah, so then the next question is, which started it? Was it an ankle injury that created that misalignment? Or do you think it was the surgery that created that misalignment? What do you think created that? And we're not going to figure that out right now because you need to be in a subjective intake, active intake with your person to know that. But all of that information should be gathered in the subjective part of your treatment plan. And if you are a personal trainer, a movement person, you're like the who, what part of my what, whenever you're first meeting with a client, you get to find out what their body has been up to before you met them. And you just simply zip it and let them talk. Because everything that they tell you in that subjective part of the intake on their first meeting, like, tell me about your body. What do I need to know about your body? They'll tell you everything you need to know. They're not going to give you the blow by blow of every single experience that their 40-year-old body has had in 40 years, but they're going to tell you what you need to know. They're absolutely going to tell you. And our job is to remain patient and open-eared and drink in everything they have to say, because they will drop in their share with you. They will drop what caused what. Absolutely. So, and we do a lot of deep diving into SOAP charting and active listening in our training for sure, because it is an acquired skill. And my invitation for you, Rhonda, because you've seen him for so long, is like to have, if you're open to it, I would invite you to have a fresh start with him. Like, okay, nice to meet you. What brings you in today? And have them go like, oh, well, Rhonda, my hip thing and my leg thing and my this and my that. Okay, great. Tell me everything I need to know about your body, and just let him talk, because there's something in there that his body gets to weigh in. I say this a lot. There's 3 of us in the room when we're working one-on-one with a client. It's us and our smarty brain, sometimes our ego, but mostly our smarts. It's them and their willingness to be there, and sometimes their fear, or their discontent because they have been to 9 other practitioners and they're still in pain and they're kind of like whatever. And then it's the body. And the body has just as much to say as we know and the client's experienced. There's always 3 of us. So the body gets to weigh in. Body gets to weigh in on like what actually happened. And most of the time, the body will give that intel to the client to tell you. And so if you let them talk without interrupting, they're like in a stream of conscious, and they'll like lay out exactly what happened, and they'll even tell you what to do about it. It's fascinating. We, in the last 6 weeks or so of our mastery training program, that's all we do is client work. And we spend 2 hours per client, and all we talk about is subjective and a little bit of objective. The case plan is right there. Like everything the client said, everything that we need to do and the order in which we need to do it is right there. I promise you. So my invitation is to have a new conversation with him. Be like, you know what? I really want to look at your body with a fresh slate, and I really want to create results for you. Let's just start with a new, fresh, clean whiteboard. I'm going to erase everything, not everything that I know about you and my care for you and my, commitment to resolving this for you, but I'm just going to start fresh. I'm going to take a step back and look at the treasure map and let the body lay it out for me. Like, get the lay of the land, and then hear what the body has to say, what the client communicated, and see if there's something more in there. Because as you mentioned, Rhonda, that and I'm happy to continue to talk with you about him too. I can't obviously give you a treatment plan. That would be unethical and probably illegal, but I'm willing to strategize with you about it. And what I'm hearing is that he had bilateral ankles, bilateral hips, low back, and now cervical spine. And what we need to find out is what order did those come in? Which one came first? Because that was the first time the body raised its white flag. Not the first time the body raised its hand, but the first time the body waved its white flag. So what happened before the white flag? Where was the white flag? Was it ankles or was it sacrum? Is it a sacrum anomaly? Or was it how his ankles were hitting the ground, and that plus the sacral anomaly didn't add up right?
That's what I think it is.
Who knows? But let them tell you. Let them tell you, right? Like, drink in the new story as if you've never heard it before. Come in with your intuition, of course, but one of the key pieces in subjective intakes is to not come in with assumption. Don't feed clients answers. I'm not hearing you say this, Rhonda. I'm just speaking to all of us in general. Don't feed clients answers because you think it's going to be a certain way, or it should be a certain way, or the last 3 people you saw with ankle or knee or hip had it, so this client must too. As soon as we jump into assumption, we are literally gagging the body from talking. We're putting it in a chokehold and saying, shut up, I don't want to hear from you. I know better than you. And that's not true. Our role is to be in service to the body, not the person. That's not even the person. That's why I'm saying, don't even get into their character and their personality. That's not what we're serving. We're serving their body. Let the body talk, and don't, cloud it out with your own opinion or previous stories or assumptions about how it works. As soon as there's an injury in the body, everything that we know about functional anatomy is mandatory to know, and it's a crapshoot. And I don't mean it's an unsolvable crapshoot. I mean, it's like, take several dice in your hands, shake them all up and throw them onto the table and see how they land. And every iteration of that is as varied as every person's body, even with the same hip replacement. It's just different history, different constitutions, different follow-up with their PT, different fear factors and mindset space that changes their cellular makeup. It doesn't matter if you've had 5 hip replacements this week that came in to see you. They're all different. The key though, is to know the functional anatomy and take them all back to how they were designed, because that's what they share in common. But we don't want to assume what's going on or anything like that. So I would find out from this person's body, Rhonda, what came first, meaning what white flag was like, I can't. I cannot walk on this ankle anymore. I cannot sit in this chair anymore. I cannot bear this pain in my back anymore, whatever the white flag was, and then rewind from there. Because there was lots of stuff going on before the white flag was waved. Sometimes we go to the place where the body, the hip replacement, and we focus on that. There is a whole storyline before the hip replacement that needs to be addressed. The hip replacement's like the finish line almost. Not exactly, but it's like that's the least of your problems. What happened to get you to need the hip replacement? And I don't mean genetics and, torn cartilage. Like, what tore the cartilage? If that's what it was. What created that responsiveness in the muscles that they needed injections for 6 months prior? What was that? Was it arthritis that changed the bony landmarks? Where they like, I don't want to go into like a whole bunch of options because again, it's limitless. But what created that white flag to be waved? There's a whole storyline before that, and that's what you're dealing with, really. Because again, like I said, surgery doesn't erase all of that. Surgery takes care of the I can't live with this part, but all of the adapting and compensating and recruiting and patterning that came before that are still there. And for some instances, I don't know if this is your client, Rhonda, but in some instances, that compensatory patterning and recruitment and lack of function or dysfunction is what caused the white flag in the first place. So if that doesn't get addressed, it will cause something else. So it's always worth it to find out what was the starting point, what was the first white flag, and what came before that. And do you need to address it? And then go forward. So it's kind of like find out what go back in history, find out what the white flag was when the body was like, I can't. Rewind from there and find out all the parts that led to that white flag. And then go forward and listen, like, did one hip surgery cause the other? Did the lumbar spine cause the cervical spine? But only after you go back. Only after you go forward in time from their first white flag, after you've gone back in the past before their first white flag. If there's lots and lots of structural stuff going on. That's my, after you just address the lever system, for most of us, it's just what's going on in the lever system. And did we address that fully? And then when you have a whole history that your client comes with, go back in time and find the white flag. Something to add, Rhonda? You came off mute. Something come up?
Someone was in the room, so I had muted. So
okay, awesome. Okay, so this was super fruitful and amazing. Is there, there's so many of you that are still here, not on camera, and that's totally cool. Is there anyone else here with a question? Anything else I can support you with? Joan, I'm not sure if I said hi when you came in. Welcome. Anybody else here have a question? We have a couple minutes left and I'd love to support you. And I will just add, hold on. I just saw your note again, Lori, in the chat. That's so cute. Thank you for that. Okay, a couple things, Lori, that you shared at the very beginning when we talked about mobility. And if you guys have questions, type it in the chat, or you can use the hand gesture if you want to raise your hand, or just come off mute and start talking. That works too. When you shared earlier, Lori, as we were talking about mobility, like, does mobility need stretching, or does this client need stretching? And do they need to go deeper to feel the stretch? Okay. I did share this last week, and I want to make sure I reiterate this. And it's also in our functional anatomy masterclass. I was listening to myself talk, and I'm like, I wish I had said it just one more time. Like, I said it 3 times, but I wish I had said it just one more time. All mobility constitutions need stretching. And the reason is because all mobility constitutions have lever systems. And the way the lever works is the action is the muscle that's contracting, and the response that allows that contraction is a lengthening. So all constitutions need to be stretching, or without it, it means their lever systems aren't working. So all constitutions need stretching. Now, you guys have heard me say stretching doesn't exist. That's true, because it's not a command from the brain. That's not my opinion. That's just neurology. But it is a response to contraction. So if you aren't contracting, you technically aren't stretching. So how about them apples, right? And so that's, again, how we administer a lengthening or a stretch is really the reason why I say, dramatically, stretching doesn't exist, to give us pause, to be like, wait, if it doesn't exist, then what am I doing? Exactly, what are you doing? Hopefully it's contracting, because that's what's going to create a stretch. So it always comes from the action of the muscle. All mobility types need to stretch, because all mobility types have a lever system. That said, it's rare that lengthening of a muscle is the solution to their pain. It's rare that lengthening of a muscle is the restoration and correction of their function. Not never, it's rare. Because we know that there's several different types of tightness. We dive into them in all types of training. We know that there's several types of tightness. Only one of them is contractile. And the contractile tightness is the one that needs stretched or lengthened. All the other tightness is not from a contracted muscle spindle configuration. So why are we stretching it? And that's in orthopedic lens. It's not a, do you know your anatomy? It's like, what's the biomechanics and the deeper knowing around that? So yes, all constitutions need stretching. And in this chief complaint that this person is bringing and presenting, is stretching the solution for them? And if it is, you got to be contracting to create the stretch anyway. That's the point. Yeah. In hypermobile constitutions, where there's lots of laxity in their connective tissue and the bones are free to move, they feel just as tight as any other constitution, because the muscles, again, we said earlier, the muscles jump in to support an anomaly in a bone formation or in a hypermobile constitution. There's a lot more required of the muscles to hold stability, muscular stability around a joint that isn't connective tissue stable. So they'll always feel tight for sure. And they still need stretching because they still have a lever system. But what they need to resolve the pain is stabilization and strengthening. And that's different in hypermobile constitutions than it is automatically check, like, do I need to do this for a client? Their constitution will give you a lot more context to what you're going to do for them now, today, what caused it, what you're going to do for them today, and long term what their treatment plan is. Not everybody needs to go home and stretch is the point, because that's not. And if you are sending everybody home to stretch, are you actually sending them home to contract? Because if not, you're not sending them home to stretch, because that's not the way the body works. The lengthening happens in response to contraction. That's lever system, straight up lever system. And then the other thing you said, Lori, was they need to go deeper. Sometimes, we used to instruct them to go deeper to feel the stretch. Sure, in a hypermobile constitution, if there's a lot of laxity, to get to the end points, they might be going further for sure. And the question always is that joint still optimally aligned? And if so, that length is okay. But if, for example, in hyperextended knees or hyperextended elbows, or any joint that you can see is way beyond its axis, its optimal alignment, no joint should ever be taken outside of the axis. Just because it can doesn't mean you should. Just not supposed to happen. And oftentimes we will see a hypermobile constitution, a Cirque du Soleil type of body, and because they can put the bottoms of their feet on the top of their head, we do that, and then we push on their knee. It's like that. Just because they can doesn't mean they should, right? So first, whether or not they can or you should or whatever, or their sensation, where is their joint relative to optimal alignment? And if they have room to go and still be aligned, then it's okay. If they're beyond where neutral is, you're done. That's not what they need. And in a hypermobile constitution, because the bones are rarely aligned, it's really easy to distort a joint and have it go somewhere that it wouldn't necessarily go if it was in relationship with another bone. So that's really what we want to look at. So it's not about whether it's deeper, or it's like, what's the alignment of the joint? Go back to joint action. Is there neutrality in that joint? And mostly we will feel a stretch more than we feel a contraction. So the question is that hypermobile joint actively working the lever system? And is there much more contraction going on to create that lengthening? And in hypermobile constitutions, it's more difficult to contract because they're not in alignment to do so often. Okay, so that's what I would look for in, you didn't ask for that, Lori, by the way, you brought that up. So I wanted to just deliver on that because I know that you're already fully versed in all the mobility constitutions. But that's a couple of things that we want to look at in mobility, and whether or not stretching and lever system is active. You guys, seriously, I can go on and on and on and on and on and on about mobility constitutions because there's just so much to talk about. There really is. And I will absolutely happily do that. I want to just highlight that next week we are not meeting on Tuesday training because we're having our summit. So please do, if you're used to coming here at noon on Tuesdays instead, please join us at the summit. We've got a powerhouse team of practitioners coming in to pour into you. So much free training. They're super generous in their offerings, lots of downloadable materials and what have you. So please do come to that. If you cannot physically make it, please register anyway, because the replays will be available for you for 24 hours. And you are welcome to watch them later that night when you're done with your client work. I know the summit is scheduled during billable hours. I totally get that. So nobody gets to be left out. Everybody gets to come. And 2 weeks from today, oh good, I'm glad you're excited, Laura. 2 weeks from today, we'll be back for Tuesday training. In the meantime, please do invite your colleagues, whoever gets to come to Tuesday training 2 weeks from today, everybody's welcome. Of course, the replays are always available for you on YouTube, and whoever gets to come to the summit, please invite them to that as well, because we all get to up level together. The more we know and do, the greater our industry is in the world. I mean, and I could go on under professional development on that for a long time. I'm stopping myself as we speak. We get to be really excellent at what we do and really consistent about that, even shoulder to shoulder with colleagues to the right and left of us, so that everybody in our industry raises up and our reputation on that also raises as well. We all win when that happens. That means that we're serving more clients and doing amazing things. So if you liked the content of today, please hit the like button and share it. Even if your colleague, friend was not here with you live, everybody's welcome. And until I see you next week, I want to thank you all so much for being here and for contributing generously and for all the amazing work that you do in the world. We're all very needed, and I'm so grateful for you. See you guys next time. Bye.